Okay, so now the path residents can join us and everyone can. So we are doing the malignant epidermal tumors. Last time everything was a cyst or acanthoma. This time, it may shock you, but a lot of things will probably be cancer. Okay, everybody get your eyeballs in. Let's make sure. Yeah, so again, when you guys are looking, this is often out of color when we do it, so close your lower aperture and adjust your condenser so that your light source looks like that. And then things will no longer be fuzzy. Okay, finish getting your eyeballs in. Okay, everybody good? Okay, so, Ying, what do you think?
In the first impression, I think of fibroepidermal pincus.
Fibroepithelioma of pincus, absolutely. You have pink strands and blue buds at the periphery. And fibroepithelioma of pincus was, for the first probably 50 years of existence, considered a benign tumor. Of course, now we consider it a variant of what? Basal cell, because this is what it becomes as it grows, right? So this is a big basal cell carcinoma growing out of a fibroepithelioma of pincus. There you have superficial BCC, you got a big nodular BCC, you've got solid BCC, and then where it worms its way between thick collagen bundles so that you can't curette it out, that's micronodular. Okay. So very well done. Okay. How about this one, Shane?
Looks so similar. I think it's a BCC.
Yeah, it looks very similar. Pink strands, blue buds, connective tissue between the pink strands. And in some of them, you can make out a little more easily. Not so much in this one, but some of them you can make out that there are definite eccrine ducts. Here you can see it. The pink strands contain sweat. They're little eccrine ducts in the pink strands of a pincus tumor. So some have considered that center that light source. Some have considered that it may actually be a basal cell that grows along eccrine ducts, which may, account for its growth pattern. Okay, Derek, how about this?
The shade biopsy, it looks like there's atypical cells all the way through the epidermis. Some pagetoid buckshot scatter. So it's probably bones.
So is most of the tumor in the epidermis, or is the epidermis up here and the tumor's down there?
Tumor's down there.
Yeah, it's usually the second one, right? So this is a dermal tumor, and the tumor is more pink or more blue?
More blue.
More blue. Has a peripheral palisade. Has areas of retraction space between tumor and stroma.
So probably basal cell.
So probably basal cell. And was this what hit your eye and suggested pagetoid scatter?
Right.
So if you have nucleus and then a clear vacuole, and then beyond that clear vacuole, pink cytoplasm, that's just a vacuolated keratinocyte.
Okay.
So it's helpful, especially in melanocytic lesions, to tell what's a melanocyte, what's a keratinocyte. If it's a keratinocyte, you'll have nucleus, vacuole, cytoplasm, desmosomal connections, those little spines. Whereas in a melanocyte, there's always cytoplasm against the nucleus, and then the vacuole's on the outside. So if it's nucleus, then vacuole, that's keratinocyte. And that's just normal keratinocyte, just with low glycogen in it. So unfortunately, a few bubbles on the slide, but let's focus on this area here. And what do you see, Rachel?
It looks kind of like a serous crust up top, and then there's some kind of normal epidermis over to the side.
So this is probably an ulcer.
Yeah.
You know, you have crust, and then there's no epithelium under, there's just dermis. So
Right.
ulcer with crust, and then off to the side.
Somewhat normal, maybe. And then it's like something kind of invading the dermis.
Yeah, so something invading, and is it more pink or more blue? Or maybe
would
50-50, hard to tell.
Yeah, I think it's kind of hard to tell. Maybe more kind like.
Yeah,
the other
maybe
ones.
more blue, but that could just be high nuclear cytoplasmic ratio. So your question could be, you know, is that squame? Is that basal cell?
Right.
Not entirely sure, right?
Yeah.
And then you've got this whole scar-like area, and this whole scar-like area also has little strands of those same blue cells.
Yeah.
So an upper ear resonant, what might you think?
Morpheoform.
Yeah, yeah. You didn't need the help of an upper ear resonant. You were fine. So that is a morpheoform BCC. So morpheoform BCC, scar-like fibroblastic stroma, and then little strands, usually 2 cells thick, of basaloid cells that just infiltrate deeply, intimately connected with that stroma. So it is a scar-like lesion, usually, that's slowly expanding on an old man's forehead. Sometimes, and we'll revisit this in a future chapter, but sometimes you can get little tadpole-like ducts, paisley tie pattern in this. So it's in what you will come to know and love as your paisley tie differential later on, because it's one of the tumors that can do that. This. That's a little folded, isn't it? Let's get something prettier for you. So, Sarah, we're just continuing to go around.
So it looks like there's a crater with keratin.
So this is keratin up here. Okay. So that's keratin on the surface, kind of sticking up above the surface. And then this is epithelium. It's kind of glassy and pale.
Right, and this kind of the border's pushing. Yeah.
The border's pushing. So is it a spiky infiltrative pattern, or is it more like a fist, just with the glassy epithelium just bluntly pushing its way into the underlying tissue?
It is.
Shockingly, it's the second more detailed description.
So it's a verrucous carcinoma.
That is verrucous carcinoma. And where does verrucous carcinoma tend to occur? So, upper ear? So foot, in which case it grows out of what used to be a wart. And it's the name applied to verrucous carcinoma on the foot?
Epithelioma caniculatum.
Epithelioma caniculatum or carcinoma caniculatum. Caniculatum means?
What?
Rabbit warren. Which is a lot like warren. Do you know what a rabbit warren is? So rabbits live one to a hole. They're actually they don't like one another, rabbits. So they live one to a hole, but those holes are together in a community. So a rabbit warren is like you're in a meadow, and then you come to this round area with a whole bunch of holes in it. Okay, and each one has a rabbit in it, right? Carcinoma caniculatum is a plaque with all these holes in it, like a rabbit warren. Okay, so that's why it's called carcinoma or epithelioma caniculatum on the sole of the foot, and it grows out of a long-standing wart. So it's not a high-risk, quote, high-risk cervical HPV type. It's a regular wart HPV type that goes on to produce cancer. Where else do they occur?
Groin.
In the genitalia, where it's called Buschke-Lowenstein tumor, or giant condyloma of Buschke and Lowenstein. It's no longer condyloma, it is verrucous carcinoma, and it grew out of
Like HPV.
HPV and a high-risk cervical type? No, a regular 6 and 11 condyloma, right? Gone bad, producing these blunt islands that push into the dermis. And what's the third place where it occurs? Oral cavity, where it's called?
Oral florid papillomatosis.
Oral florid papillomatosis, and it grows out of, this may shock you, a wart, right? So it's ordinary wart gone bad, not high-risk HPV type gone by way of Bowen's. Okay. Okay. So, Michelle.
This looks like it's on the bluer side.
It's on the bluer side, and this may actually not be fair to you. Let's jump to Rob, because this needs a third year ready to graduate. So clinically, what do you think this might have looked like? If the patient's down here.
Okay. I mean, it's like a focal papule, maybe?
Yeah, like a bump,
Right.
a papule, exactly. So this was a small papule, and what features do you have here?
So I mean, it's kind of got like a crater-form architecture. Would you say? I mean, is that what you're looking at?
Crater form is usually endophytic. So here, anyone want to take this? What are all these things? Yeah, and with a little shrunken. So it looks kind of maybe mucosal with all of the vessels and with no collagen bundles. So maybe it's on a mucosal surface. And then these things with the pycnotic nuclei and the vacuole are probably coilocytes, right? So it looks like a mucosal wart. except that this mucosal wart has pretty high-grade atypia. Now, some of it's just coilocytic, where the coilocyte is, but there's also atypia away from the coilocytes, and there are atypical mitoses. So, normal mitotic figures don't look like a Mercedes-Benz emblem, right? So when you see that, that's, okay, let's go. So those online can, let's find that for them. They're kind of off kilter. There we go. You can see that little Mercedes-Benz or like a rocket ship taking off there. Okay. So that's a little different from a normal mitotic figure. So you have abnormal atypical mitoses. You have coilocytic atypia, which doesn't count. But then you have atypia and high nuclear cytoplasmic ratio in the non-coilocytic population as well. So what do you call that kind of mucosal wart gone bad? Boenoid papulosis, right? It's sort of half wart, half Bowens at this point, right? So it's a wart going bad, Boenoid papulosis. The term was coined by Dr. Hellwig at a time where the treatment for Bowen's disease on a male penis was simple excision, and the standard treatment for Bowen's disease anywhere on a vulva was radical vulvectomy. And he was receiving radical vulvectomy specimens for women who had multifocal things that looked like warts with a little bit of atypia in them. And so he coined a new phrase and told the surgeons, this is not Bowen's disease, stop doing that. This is Boenoid papulosis. This is something different. You're way over treating this. So that's where the relevance of that term came from. Nowadays, the treatment for vulvar disease with most enlightened physicians is, more similar to what it is in a male, although we still see some women who get radical vulvectomy for Bowen's and Boenoid papulosis, which is like back to the 1940s, right? Way over treatment for a disease that can be treated with imiquimod topically and other less destructive, less disfiguring therapies. Okay. So, Michelle, how about this one?
So, it looks like almost strand-like.
Yeah, almost strand-like, and every strand encircles. Some of them are encircling collagen, and some are encircling this blue, stringy, almost foamy-looking stuff that could come out of your nose in winter when your nose is running. So that's mucin, right? That's snot, basically, right? So mucin or gobs of snot in pockets in the tumor. So do you know any kind of blue basaloid tumor that encircles gobs of snot?
There's infundibulous cystic.
So infundibulous cystic BCC is pink strands, blue buds radiating outward. They don't anastomose into a net, and they have horn cysts. But there can be mucin in the stroma, but never within the tumor islands. Here, most of the mucin is actually in the tumor islands.
Fibroepithelium pincus.
So fibroepithelium of pincus has an anastomosing pattern of pink strands, and the only blue are the buds on the tips. Adenoid BCC, which is overwhelmingly the most commonly missed form of BCC. People think it must be something more, fancier than a basal cell. So it's a pattern that's frequently missed. It's cribriform, which means it's sieve-like, And in every hole of the sieve, you have snot, you have mucin. So you see a blue tumor, and exactly. So when you see this in the cribriform pattern, then snot hard diagnosis, right? Snot hard. That mucin gives away the diagnosis.
Sounds like a good test question.
Common, uncommon variants of common things, right? Uncommon things that are non-controversial and uncommon variants of common things are things we all need to know in our scope of practice, right?
Yep.
Okay. So, Caitlin, how about this?
Alright, so this one looks pinker, but I'm wondering if that's
It
just
looks
the-
pinker. So this one is predominantly pink, not
Right.
blue, right?
Right.
In fact, it's a similar color to the surface epidermis. Even at this power, you've got all this tiny little nuclei, right, with all that pink. And now, how about nuclear cytoplasmic ratio in the dermal component?
So, I mean, I can see the nuclei at this level, and they're a little bit larger, so
Yeah.
probably beta.
So a higher nuclear cytoplasmic ratio, which
Right.
usually goes with something that's A, benign, or B, malignant.
B malignant.
Be malignant. Well done. Okay. And by the way, you guys, if you want, you can help yourself to the treats as you're getting these right. So far, everyone has carefully avoided the ipecac, which is great. So you've got something that is pink and invading into the dermis, has a high nuclear cytoplasmic ratio, and in areas forms these little keratin pearls.
It's probably a squame.
It's probably a squamous cell carcinoma. Very good. Well done. And they can be spiky and infiltrative, or they can be less spiky and blunt, as in verrucous carcinoma. Okay. Rob, how about this?
So we have some hypergranulosis in the center of this,
Hypergranulosis in the center.
right? Which
I
goes-
know when things get picked, like squames, there's hypergranulosis at the periphery, but what does hypergranulosis in the center imply?
So it implies more like Ka. So
Like
PDH
keratoacanthoma. Okay.
So and it does, at least in this area, it looks a little crateriform, and then looking like closer at the periphery, I guess you would look for like elastin trapping and
Yeah, so helpful clues,
Eosinophils.
elastic trapping, eos in the stroma,
Which that makes-
neutrophil microabscesses, which don't form until it gets really crateriform.
right.
So behavior of a Ka versus a conventional squame.
So it behaves a lot less aggressively, except after biopsy, in which case it'll tend to explode.
Yeah. So if you biopsy an ordinary squame, what happens to its growth?
Usually you don't get like a rapid period of
Yeah,
growth.
nothing. It just keeps on growing. It doesn't care that you biopsied it. Kas get mad. So when you get something that explodes after you've biopsied it, it's just told you it's a Ka, right? It's the easy time to lose your wits and say, this is the worst squame on the face of the earth. Look at how it's exploding after I biopsied it. And there are, cases like that in the literature. There's this little bump on the lip. Someone biopsies it. Now it's infiltrative through half the lip. Oh, good grief. You've got to cut the patient's face off. No, that's when you don't cut the patient's face off because it's just a keratoacanthoma. And how can you treat Kas?
So intralesional methotrexate,
Yeah, intralesional
especially if it's
methotrexate,
in echo.
systemic psoriatic doses of methotrexate, intralesional 5-FU.
Right.
Topical 5-FU under
Chemo
occlusion
wraps.
if it's smaller, which is what we do for chemo wraps. So this is from an 80-year-old woman, and it's on the shin. What happens to this one when you take it off?
Probably get like 5 or 10 more.
So the old quip is you kill one, 5 come to the funeral. Right? That's what happens on the shins of old women with Kas. And unfortunately, we have seen people who are put on systemic chemotherapy for, quote, widely metastatic squame on the shin. It's eruptive KAs on the shin. You don't need systemic chemo. What you need is a chemo boot, which is you slather 5-fluorouracil cream on the leg, you wrap it in an Una boot, and it goes away. Just heard from Katie Eccles. She's treating a patient who's, exactly classic like this. And often you not only see those eruptive KAs, which are, 5 or 6 crateriform lesions now on the shin, but in the background, it looks like all these little prurigo nodules showing up. Every one of those is going to be a KA too. So you just keep chasing them if you try to do it surgically, or you can slather the leg in Effudex cream, wrap it in an Una boot, repeat that once a week, once or twice, inject any of the big ones, and it all comes down and goes away. Okay.
Like couple cases of the GA, right? On the temples that have grown quickly after biopsy.
Yeah, I had them.
We've had an issue of management because they're getting
They
the
all get
plastics and
called squames.
So
they're
that happens, and they get really big in a real hurry, and that's when you don't
inject,
lose
like,
your
a
wits.
squame on the temple. It's like, I think they're, you still
Exactly.
inject it with methotrexate, right? Or you could.
How often do keratoacanthomas show perineural invasion on path?
They do.
It's actually up to 50% can show perineural. So the pathologist is telling the surgeon sometimes this is a perineural squamous cell carcinoma, as bad as it can be, and it's just a KA. KAs very commonly have perineural extensions. So now the one thing KAs are never supposed to have is they're never supposed to have acantholysis, right? So is that acantholysis? Go higher power. It's a fake out. See all those little desmosomal attachments stretched out and hanging on for dear life? That's just spongiosis. If it were acantholysis, those cells would be round, not angulated, and there would be no desmosomal attachments. That's the whole idea of acantholysis, right? Why are things called acanthocytes? What does acanth mean? It means spine, right? Acantholysis is lysis of all these spines. Do you see lysis of these spines, or do you see very intact spines all hanging on in the face of spongiosis, right? So that's spongiosis that is not acantholysis. KAs are allowed to have spongiosis. They're not allowed to have acantholysis. If there's acantholysis, it's not going to behave like a keratoacanthoma. Got to keep an eye on the time. Okay, it's a little pale.
Very pale seeing this slide.
And when it's pale, it's usually worth looking up on the screen because the camera will correct for the pallor. Okay, and it's still a good slide. If you looked at growth pattern, these multiple buds hanging down like garlands, surrounded by a fibromyxoid stroma, what would you think? Basal cell. Why is this one all composed of clear cells?
Because you can have a clear cell base.
In fact, you can have a clear cell variant of anything, right? And you can have a granular cell variant of anything. So just, one of the laws of the universe. Everything comes in a clear cell flavor and everything comes in a granular cell flavor. Doesn't make them something else. Okay.
This looks almost like a infiltrative BCC.
Like an infiltrative. So what's the difference between infiltrative and morpheoform?
So morpheoform's more, there's going to be a lot more collagen between very small strands, while infiltrative can have more of a spiky look to it. You can still have fibromyxoid in areas, but again, there's going to be some.
So morpheoform typically looks scar-like clinically, and histologically it has lots of fibroblasts, and each one is forming tiny little thin new ropey strands of collagen like a young scar, and there are 1 or 2 cell thick strands of basaloid cells. Here you have something that's infiltrating between big mature collagen bundles, you have a fibroblast-rich stroma, but you still have some retraction space between tumor island and stroma, whereas, as you'll learn later in trichoepithelioma, the clefts only occur within stroma, so there's collagen on both sides of the cleft, as opposed to basal cell, where there's epithelium on one side, stroma on the other, and a space. And it is spiky. And if you remember that spiky things, your mom taught you this, spiky things will hurt you, right? There is no spiky benign tumor, right? There is no spiky benign adnexal tumor that's basaloid. The center of a desmoplastic tracheomoma is as close as you get to that, but there is no spiky basaloid. There's no spiky trichoep, right? That doesn't exist. So remember, spiky things will hurt you, just like your mom taught you. And so if it's spiky with a fibroblast-rich stroma, it's an infiltrated BCC. So we got to pick up the pace a little bit here. But we're getting some of the important teaching points down at the beginning. Things that are clinically important.
Pretty broad lesion here.
So pretty broad lesion. So clinically, you think this was a macule, a papule, a plaque? Probably a plaque lesion, right? Because it would have been indurated and broad and flat-topped like a plateau, right?
Yeah, I'm wondering if it's like a buttressing around the sides. I'm not sure. Or maybe more just like Bowen's.
So you have highly atypical windblown anaplastic cells. You have clear cells. Is there a clear cell variant of Bowen's?
There's a clear cell bone.
I mean, the answer is there's a clear cell variant of everything, right? So that wouldn't surprise me. And can Bowen's form little clones, little nests of atypical cells within the epidermis?
Yeah.
Can Bowen's do a buckshot scatter of individual atypical cells within? Yeah. So this is very Bowen's growth. It can be solid, full thickness atypia. It can be buckshot scatter. It can be clonal nests. Those are all things Bowen's likes to do. Bowen's likes to invade the full thickness and full width of the hair follicle. You see the little hairs in the middle, right? And you see sebaceous gland down below. Whereas AKs just grow down the outside of the follicle. They don't replace the entire follicle. This is not invasion in Bowen's. These are blunt, and each one of these is just where it's filled up a follicle, right? So that, and sometimes Bowen's, like this pattern, isn't doing that much in the surface epidermis. It's just kind of skipping follicle to follicle to follicle, probably because that's where it originates. So follicle is, Bowen's is most likely an anaplastic squamous cell carcinoma in situ of the follicular epithelium.
Invasive Bowen's is worse than an SCC.
And if there is ever a booming voice from the sky that tells you you must choose between a conventional squame and invasive Bowen's, take the conventional squame, because Bowen's is an anaplastic adnexal type carcinoma arising from the hair follicle, and when those invade, their behavior is nasty and metastasizing. Right? So there will be no booming voice from the sky asking you that question, but just in case you've got your answer down, right? Here you see crushing of a basal layer. Bowen's can do that. Paget's can do that. Melanoma can't do that because it originated at the basal layer. That doesn't belong in that box. Let's see. Okay.
Big piece of tissue here.
Big piece of tissue, and what do you see?
Some deeper lympho, nodular infiltrates down there.
Nodular lymphoid aggregates and a dense scar-like stroma. What do nodular lymphoid aggregates and a dense scar-like stroma mean?
Something spindle cell. There's some desmo.
Yeah.
More people from basal or spindle cell squame.
Yeah, or
There's something bad going on.
so normally, what's the ultimate bad that normally means?
No, like metastatic melanoma, perhaps. Or
Not-
malignant melanoma.
Yeah, what type?
Desmoplastic.
Desmoplastic, right? So desmoplastic melanoma. So when you see desmoplastic melanoma, the diagnosis is usually missed. It becomes a huge tumor, and when you look back at the original biopsies, they were scar-like lesions, which is what they were called, scar, but they had these nodular lymphoid aggregates. Jen McNiff, a wonderful dermatopathologist at Yale, is fond of saying lymphocytes are way better at recognizing melanomas than pathologists are, right? Those nodular lymphoid aggregates, listen to the lymphocytes, right? They're there for a reason. So nodular lymphoid aggregates in a scar-like lesion immediately buys you an S100 or a SOX10 for desmoplastic melanoma, because other immunostains are unreliable in any spindle melanoma. Only SOX and S100 are reliable. In this case, SOX and S100 were negative, so all is well. Send the patient home, right? In this case, regular keratin, stone cold negative, P63 negative, high molecular weight keratin showed infiltrative strands of squame all through. This went down into muscle and fascia and was a monster. But, almost everything here that looks like little fibroblast nuclei are actually squamous cell carcinoma. And they're all positive, but only with high molecular weight keratin. As these things de-differentiate and become like facultative fibroblasts, you have to throw multiple keratin-type stains on them, and hopefully one will be positive, either a P63 or a high molecular weight keratin. But ordinary pan-keratin, AE1 and 3, often falls flat on its face. And you wouldn't simply dismiss the case because those lymphocytes are down there telling you there's something going on, right? Listen to the lymphs. Okay, it looks awfully pale, but it's not actually the stain because that epidermis out on the side is fine. Why is it so pale? Glycogen. Or swelling of organelles. Clear cell change is often ultrastructurally just swelling of all organelles rather than glycogen deposition. So sometimes they're glycogen positive, sometimes they're negative, and it's just organelles. How about the growth pattern here?
It's kind of bulbous there at the side.
Bulbous, and how about in here?
A little buckshot.
Little buckshot. Okay. So what do you think this is?
Could be a clear cell bones.
Yeah, like clear cell bones. Remember, there's a clear cell variant of everything. This is full thickness, high nuclear cytoplasmic ratio, buckshot scatter. So Bowens or Bobo, or in the South, just Bo. Everyone's got a nickname in the South, so Bo. We just saw Bo. Makes it sound friendlier. Okay, so how about this?
The stratoconium is compact paracartosis,
And what are these vertical columns of blue in it? What would you call that?
and the flag sign.
Flag sign.
Yeah.
Brilliant! Someone needs to pass that easy button over here.
Let's give her some. How that works.
That was easy.
So a compact red horn with vertical columns of blue is the flag sign, and the flag sign is typical for a malignant horn. Tells you there's something malignant under it. And tell me about the malignant thing.
And they are full-thickened atypical cells. Looks like it's a bonoid AK.
Yeah, so full thickness, atypical or anaplastic cells, so could be Bowenoid AK or could be Bowen's disease.
Yeah.
You know, either one. And then over here,
We can see the infiltrate into the derms,
yeah,
and it's a Bowen disease.
yeah. So if this is all still Bowen's infiltrating into the dermis, then
I see.
its behavior is going to be bad, right? These are also, though, they're kind of smudgy blue cells, and they're forming parallel lines that then anastomose, similar, reminiscent of the pattern of trabecular bone. So anything else that forms smudgy nuclei, blue cells in a trabecular pattern, Shane?
They want to get a few stain, probably Merkel.
Probably Merkel. And Merkel occurs in conjunction with Bowen's about 1,000 times what chance and chance alone would predict. So Merkel in collision with squamous Bowen's is pretty common. And invasive Bowen's is bad. Merkel in association with Bowen's is ultra bad, right? Merkel's really, really, really bad. I mean, you're often dead in 6 months with a Merkel. So what clues to Merkel? Blue smudgy cells, parallel wall-like structures that anastomose in a pattern similar to trabecular bone, which is why its original name was trabecular carcinoma. And so you probably want to get neuroendocrine stains, which we'll revisit in a later lecture. But, could just be invasive Bowen's, that's bad enough, or it could be even worse. Right? Okay, how about this?
Looks like pink strands.
Pink strands, blue buds, and the pink strands radiate outward from a center or anastomose in a net-like fashion.
Anastomose like a pincus tumor.
Like a pincus tumor. So radiating out from a central follicle-like structure is infundibulous cystic BCC, anastomosing in a net-like pattern with eccrine ducts within the pink strands is pincus tumor. Both are indolent forms of basal cells, so if you call it one versus the other, you're probably not going to hell for that one.
See some kind of spiky islands of
Spiky?
basaloid cells.
Now, I don't see any retraction space, and I see a fibroblast-rich stroma, and I just read in my book that that's the kind of stroma you get with a trichoepithelioma. So this is a trichoep, right?
Wrong.
Wrong. Do you have children?
Yes.
Do you let them play with spiky things?
No.
Because spiky things are?
Painful.
Yes, or bad. Yeah. So this is?
An infiltrative BCC.
You are correct, sir. That is an infiltrative BCC.
Crush. Have some Epicac.
So this one looks like it has some buckshot scatter.
Buckshot scatter?
Yeah.
Buckshot scatter of cells that have a lot of cytoplasm or almost all big nucleus?
Almost all big.
Buckshot scatter of cells that are almost all big nucleus within an epithelium and then full thickness involvement of the follicle? What could we be looking at? Bowen's. And when you look at the horn, it's a compact horn, and look at the parakeratosis. That's not small, flat parakeratosis. That's big, dark, ugly, hyperchromatic, malignant parakeratosis. Okay.
So, looks like this is more within the epithelium. I don't see much invading into the epidermis. Looks like.
What's the if the epidermis is pink, is this bluer than the epidermis or about the same color as the epidermis?
This is bluer.
Got some parts, like down at the bit, at the ends there, but most of it I'd say is probably about the same color. You know, if I had to describe it, I'd probably say this is pink strands, blue buds. And there are lots of horn cysts.
It says infundibulous cystic.
So it's infundibulous cystic. And this one is probably as close to anastomosing as you'll ever see. They're usually more like this bit where its fingers projecting outward rather than anastomosing net. Okay. But that's infundibulous cystic BCC. Okay. Eye on time. Okay. So how about this?
This looks like there's a lot going on.
Big mass of blue cells with peripheral palisading and retraction from the surrounding epithelium, so probably
A basal.
probably a basal. And when we look higher, there are some 40-pound nuclei all through this basal. There are these massive, monstrous nuclei. That whole thing is one nucleus. That's one nucleus, that huge thing there. So monstrous cells in a basal cell. What do they mean in terms of the prognosis of the basal cell? Not a blessed thing. Doesn't change the behavior at all. So a spiky infiltrative growth pattern, that changes the behavior. That's an aggressive BCC. These big, impressive monster cells, nothing. Just like a regular old BCC. You ignore them. They're fine. And that's in general, monster cells mean nothing. They are hyperdiploid. So the spindle cells just went awry. The spindle cells aren't working anymore. So instead of undergoing mitosis, it just keeps getting bigger and bigger and bigger and bigger. But it doesn't change the behavior of the tumor. And that's pretty much universal. That monster cells don't mean a whole lot.
This looks like another basal cell.
Looks like another basal cell, and it has strands, and it has fingers, and they're sitting in a myxoid stroma with retraction space.
Cystic.
Yeah, I mean, some people would call it, in fact, the person who signed this out called it infundibulous cystic. I might just call it nodular. I mean, both are indolent types. It doesn't matter. Right. You can define that as long as it's all sitting within a myxoid stroma. You can define it with a curette. All that myxoid stroma just curettes out. When it worms between collagen bundles or has new scar-like collagen, that your curette just slides over. So you can't define the tumor extent with a curette, which is why those are more aggressive types, basically.
So, looks like there's some atypia in the epidermis.
Yeah, so if you look at the surrounding epidermis and you look at the cellular dynamics, the basal cells start as kind of vertical columnar, and then they become horizontally oriented, flat, and become flattened out squamous cells. That's normal epidermis, right? That's normal epidermal kinetics. You go over here.
What's full thickness?
Yeah, are these things really flattening out, or are they staying round towards the top?
Staying round.
Staying round towards the top. But when you look at it, it's not that anaplastic, and the cells aren't that big. It's small with kind of disordered kinetics. And when you look at the horn, instead of being a compact horn, it's a coarse basket weave that looks like someone's taken a tiny little biopsy punch, and cut little holes out of a stratum corneum. So they're all those little round holes, giving you a coarse basket weave. What's that kind of horn usually typical of?
it's usually more, it's benign, like, it's not usually even a malignant.
So you normally see that coarse basket weave in what lesion?
Warts.
Verruca plana, right? So you've got a horn that looks like it came from a wart, and you have a small cell, windblown, pigmented version of Bowen's. That's genital Bowen's. That's anogenital Bowen's. It's HPV induced, right? Very recognizable. There was a paper that we published in JAD, I think it was JAD, last year that looked at all the Bowen's types and the growth characteristic. This is recognizable as HPV-induced Bowen's. And it has all of those characteristics. When you look at it, first off, the epidermis isn't that thick. You look at its scan, you could almost blow past it as a normal epidermis. The corneum isn't compact, it's not parakeratotic, it doesn't have a malignant horn. It has a coarse basket weave horn like a flatwort. The cells are small, but the kinetics are wrong, and it doesn't mature and flatten like squamous cells, and it's hyperpigmented. A classic paper was published as pigmented lesions of the nether regions, because at the time it was considered vulgar to say penis or vulva, or you weren't allowed to say things like that. So it was pigmented lesions of the nether regions, right? Which, was Bowen's, is what they were trying to say. Was when Bowen's happens on your penis, it's pigmented. That's what the authors wanted to say. And at that time in the 40s, you were not allowed to say that. So it was pigmented lesions of the nether region, of down there, right?
It's not, so this isn't Bowenoid papulosis.
This is not Bowenoid papulosis.
How would you sign this out?
I would sign this out as Bowen's disease, and then I would say this pattern is usually is HPV associated. And this is what you usually see, like anogenital. You see it on digits because digits visit the anogenital region, right? So you see it digits, you see it sometimes lips and tongue, all things that may have occasional connection to the anogenital region, and so you get sexually transmitted cancer, anogenital Bowen's, right?
Would you treat this more conservatively, like we were talking earlier?
This is the sort of thing that is usually like cryo and imiquimod, and you don't want, they don't tend to go deep along follicles. They tend to be very extensive, and more importantly, they're multifocal because they started as little wart inoculations, right? So they don't grow in a contiguous fashion. So you try to do Mohs. Mohs doesn't work for these because it's a true multifocal cancer of origin from all these inoculations of wart virus. And so, they do well with topical 5-FU, they do well with imiquimod. Remember, with 5-FU, if you're using it on a penis, what don't you want them to apply it to? Scrotum. Right? So penile skin and penile mucosa, very, very resistant. We can, when you have intraurethral extensions of Bowen's or condyloma, you take a 5-FU tube, you take a tube of xylocaine jelly. Xylocaine jelly is made for cystoscopy, so it comes with a little cone. That cone thread fits the tube of Effudex. They spread their meatus apart, they stick the cone in, and they squirt until their urethra is full. And they say, how will I know when it's full? And the answer is, you'll know. You'll know, right? And the patient comes back the next visit and says, you were right, I knew. Right? And they leave it in there for about an hour while they're drinking lots of water, and then they pee it out. And that's how you treat intraurethral Bowen's or intraurethral condyloma, and you don't scope them, because if you scope them, then they now get bladder papillomas, right? So you don't scope them until you have treated and every last meatal wart is gone. Then they can scope to see if anything's left. They will start to get sore. When they get sore, they've got the xylocaine jelly. When they get real sore, they stop, let themselves heal for a few days, then they restart, and they keep doing that until all the warts and all the lesions that they can see are gone. And it's the urethra does not, there are 30 years of data on treating like this. You do not develop urethral stricture, whereas you go in there and you try to treat it surgically, you're going to get urethral stricture, right? And the only thing is, when they are done peeing, they shake, they blot, they don't let those drops of urine impregnated with the 5FU drip onto their scrotum, because if they do, it is a memorable experience, right? If you look at the ventral surface of the penis, there is a triangle of scrotal skin that goes about 2/3 of the way up the ventral surface of the penis. When you are treating venereal warts on the penis with 5FU, they must avoid that. Otherwise, you see them back in a week, and there's no reaction except this triangular, wet, sticky, painful, eroded area that sticks to the shorts. So it's memorable, exactly. So scrotal skin reacts very, very differently to the 5FU. But your point is, this is exactly the kind that you're not going to approach surgically, which is why we have built-in comments and the like. And the other important thing is, this is on his shaft. You need to know what her cervix status is like, right? So, we're derms. The name of our specialty used to be dermatology and syphilology. In all of the Latin and French-speaking countries of the world, the name of the specialty is still dermatology and syphilology, because it's, syphilis is back. VD is a big part of what we do. And so, we will show pictures of genitalia in conference, and we will talk about it because it is one of the things that is in our scope of practice. And one of the most horrible things that ever happened in medicine was early in the AIDS epidemic. There was a study that came out of the Cleveland Clinic where they looked with electron microscopy at latex and natural membrane condoms, and both appeared to be solid structures. But after simulated use, and they used melons and dowel sticks, but after simulated use of the condoms, there were holes all through the natural membrane condom much larger than the size of the viral particles, and those did not occur in latex condoms. And they sent it to the New England Journal, and they sent it to a number of other, and every editor said it was a vulgar article and they would not print it, and it could have saved thousands of lives. Because, it was 5 years later that the CDC put out the warning that natural membrane condoms offered no protection against HIV, or limited protection. And, it was like back to the 40s, where we don't talk about things in polite society. We don't talk about things like that. And, I don't know how many thousands of people died needlessly when an article could have been published that would have prevented it. So
is typical treatment like 30-day? I mean, is it like similar to?
Usually, in my hands, they treat for about 10 days and they get sore, and then they let themselves heal for about 5 days. And it's 3 to 6 cycles of treatment before they clear their warts, typically. Bowen's actually takes a little longer than just condyloma, and they'll sometimes get recurrence. When you see pigmented Bowen's and Boenoid papulosis, it's often sessile, it's pigmented, it can be either velvety or shiny, but they're often pigmented lesions. So they're not cauliflower-like. They're more sessile and they're often pigmented. And so those are all clues, and we're out of time. And I got on my soapbox at the end there, but it's one of the important things that we do.
I had a guy that kept requesting 5. The guy that kept requesting for center 5.
I'm sorry, say it.
I had this patient, and I got a request, and he wanted 5FU for his inner groin. So I assume that was probably getting on his scrotum. I don't know. He had like no indication for it. He just said it worked when he was getting boiled. So
You
we're
do
like,
the Michelmon the same as like 10 days.